Well, good morning or good afternoon or good night, everyone, depending on where are you connecting. This is an international meeting. We appreciate you are joining us today for this mini online seminar series that this is an educational partnership between the ISN and GLOMCOM. This is our seminar number 4, and we'll be reviewing the renal involvement in lymphoproliferative diseases. And you know me, I'm Carmen Avila-Casado. I'm representing the Renal Pathology ISN working group. And, you know, I would like to introduce our group. The ISN Renal Pathology working group has a representation from all parts of the world. As you can see here, our chair is from Egypt, Wessam Ismail. And we have a representative from the United States, from Korea, from Europe, Kenya, from Africa, from Russia, Philippines, Czech Republic, India. So we try to cover all continents regarding renal pathology. Our mission is to cover the following. We want to bridge gaps in kidney care through advocacy and collaboration with our global partners. As part of the ISN, we want to build capacity with healthcare professionals via granting programs, education and research opportunities for everyone. We want to connect communities in order to develop a stronger understanding of how to manage kidney diseases. And we want to engage in collaborative effort to improve prevention, diagnosis, and treatment. So one of our collaborative efforts is this one, joining with the GLOMCOM and bringing to you education in renal pathology provided for our members from the renal pathology working group. So today, it's my pleasure to introduce Surya V. She is a professor of pathology, director of electron microscopy laboratory, and chief of renal pathology division at Weill Cornell in New York. She has several awards from the Renal Pathology Society. She has the very prestigious award that is the Jacob Church Award. And she has also awards for the commitment and service to pediatric nephrology, the Council of Pediatric Nephrology and Neurology, and recently she has another one that is not enlisted. She's a contributor to Diagnostic Pathology, Renal Diseases and Transplantation Pathology Series. She was our president, so she's a past president of the Renal Pathology Society, and she has recognition of contribution of service to pediatric nephrology, the Council of Pediatric Nephrology and Neurology, Kidney and Urology Foundation. She has over 165 publications, including 3 book chapters. She's the co-director of since 2000 to date, to the International Summer School in Renal Pathology in Italy, that we hope is coming back soon. And she's member of several working groups of disease classification. So she's an outstanding speaker and teacher. Over the years, she has provided many contributions, especially in education. So it's really my pleasure to introduce her. Surya, the floor is yours.
Thank you very much, Carmen, for the kind words. I don't know if I deserve them, but now I would like to see if I can share my screen. And as where am I? I lost you.
Down in your computer, just say share your screen. Okay.
Share my screen.
Okay, perfect.
Yes. But first, good morning, good afternoon, good evening, and good night to all our colleagues around the globe. And I would like to thank the ISN programs, GLOMCON, and the ISN Path Committee, which Dr. Avila has just mentioned, for giving this opportunity to share some of what we have seen. This particular subject is off the beaten path, but nevertheless, we do see these cases from time to time where cases are known who come with monoclonal gammopathies or with lymphomas ahead of time. But at other times, it is the renal pathologist or the nephrologist who are suspecting and confirming these diagnoses and for what renal involvement has taken place. Having said that, a brief outline of this talk. This is a very ambitious talk, and I hope it will be useful to you. So after the introduction, mention briefly about the kidney involvement, the extent of it, and very briefly our experience over the years in terms of the numbers. And I will then show you the bulk of the talk will be 5 cases to illustrate the scope of renal involvement and the type of diseases that we will see. I will also briefly mention some additional examples of other renal entities that go along with these with this subject, and of course the summary and conclusions. So hemopoietic malignancies comprise all forms of myeloproliferative disorders, lymphoproliferative and plasma cell disorders. In both children and adults, it is not a purview of only adults. It spans some of the acute leukemias and Burkitt's lymphoma and others. They also occur in children, which can affect the kidneys. Almost now, we will restrict ourselves today to mainly lymphoproliferative disorders. Almost all forms of these malignancies, Hodgkin's and not Hodgkin's, both in immunocompetent and immunodeficient settings, age-related lymphomas, lymphoproliferative disorders, viral-induced lymphoproliferative disorders, and post-immunosuppression related immunodisorders. All of these can be associated with renal disease, and thankfully, the incidence is fairly lower than all the other medical kidney diseases that we see. So the extent of involvement, the kidneys can be involved by direct infiltration, or they can involve specific compartments of the kidney, particularly monoclonal proteins, and sometimes infiltration by the lymphoma cells as well. Glomerular lesions secondary to cytokines or circulating soluble factors, podocytopathies, and other paraneoplastic effects such as amyloidosis, acid-base balance, which we will not deal with today. And this is what I would like to also mention, which is that this renal disease may be the initial manifestation of an underlying lymphoma or leukemia. And we may be the first one alerting the clinician or even the hematologist that this patient may be harboring one of these conditions. Or the kidney may be the location of a primary lymphoma, which may be diagnosed by a biopsy or by a nephrectomy specimen. So treatment of the underlying lymphoma in most cases has paralleled partial or complete recovery of renal disease in most cases, unless some of the damage that has occurred in the glomeruli or within the parenchyma is irreversible at the time. And we have also seen the reappearance of the renal disease when there is heralding a recurrence of the underlying lymphoma. And one of the cases that we had, mantle cell lymphoma, had a podocytopathy with nephrotic syndrome. They treated the lymphoma and the patient got better. The nephrotic syndrome went away. And 2 years later, 2.5 years later, the nephrotic syndrome appeared first. And this time I saw focal segmental sclerosis, and I told them to start looking for the lymphoma, and they found a recurrence of the lymphoma. So that is also possible. So this is the overall picture of what can happen in hemopoietic diseases, excluding myeloma. As I mentioned, direct parenchymal infiltration, which can be primary or secondary or angiocentric. And I will show you an example of that from our files. Indirect effects can be seen when these patients can get treated. For example, tumor lysis syndrome. A recent publication had mentioned that when these patients get treated, this is the incidence of tumor lysis syndrome is highest with uric acid nephropathy or hyperkalemia and others. And there are a number of other renal lesions that can occur as a result of treatment or as a result of the lymphoma. But once we start to look at the specific effects that these lymphoproliferative disorders may have, we divide again into Hodgkin's, non-Hodgkin's. Hodgkin's, usually it is a podocytopathy as a result of certain soluble factors that may be released or amyloidosis. Non-Hodgkin's, both T cell and B cell lymphoproliferative disorders, both lymphomas and leukemias, can affect the kidney. Now, the B cell diseases are the ones that produce monoclonal gammopathies, as we all know. They can be cryoglobulins, non-cryoglobulins, or other, which can occasionally cause CAS nephropathy or light chain tubulopathies. So these are just some selected references. I'm not going to go into the details, just to say that over the years, there have been numerous reports of cases, 15 cases, 20 cases, 18 cases, that people have addressed from larger centers, that what they have encountered in their case files. So it is not uncommon to see this in a renal biopsy practice or in a nephrology practice. So briefly, I just wanted to share what we have seen in our own institution, excuse me, for the last 20 years. And I just broke them down so that they make some sense clinically how they present. If you look at the age and gender incidence, although we do see occasionally younger age groups, majority of them are in the adult and older age groups with maybe some male predominance. I don't know if this is biased or not, but this is what we found. And the duration between the history of lymphoma and renal disease was like 0 to 10 years. So the 0 meaning that we may have been the first to identify a malignancy at the time. Clinical renal presentation is as usual, as we see with any other medical kidney disease, proteinuria, nephrotic syndrome, and a nephritic picture, acute and chronic kidney disease, etc. But when you look, and when I broke them down into mainly glomerular lesions, or a combination of a glomerular lesion with parenchymal infiltration of the lymphoma, which can happen, or just plain involvement of the renal parenchyma, I saw some arbitrary patterns. Proteinuric state and or nephrotic syndrome or a nephritic picture was more common when glomerular involvement was noted. And that is something that you can see here. But as we go down, the slow rise in creatinine is seen more with patients who have renal parenchymal involvement, both with or without the glomerular lesions. And imaging studies have identified larger kidneys or nodular kidney masses in some of these patients before or later. Often we may see monoclonal gammopathy, particularly with the B-cell lymphomas. So coming to the other end of the hematologic side, what do these different types of Hodgkin's or non-Hodgkin's lymphomas mean to renal disease? How do they contribute towards kidney disease? Again, with the same breakdown that we see here, at the bottom, you see the more differentiated B-cell lymphomas, that which may have monoclonal gammopathies, produce higher incidence of glomerular lesions. The glomerular lesions that you see with Hodgkin's or acute leukemias may be more podocytopathies or direct infiltrations. So this is the general picture that I wanted to project. for you with or without monoclonal gammopathies. So now we go to case one. This was that I would like to mention here that all these cases are from our files, and all the images that I will show in this talk are from our files as well, just to share our experience with you. This is a 60-year-old female with a long history of chronic lymphocytic leukemia, about 12 years. And now they started to find that a year ago, her creatinine was 1.0 with a little bit of proteinuria, now increased to 4 grams, and the creatinine increased to 2.7. And the WBC count at the time was still 80,000 because of the CLL that she had, even though I think she was being treated somewhat. Urinalysis did have the proteinuria. A few RBC were also seen, and there was a serum as well as urine monoclonal spike that was not detected at the time. So all the viral infection studies, serologies, autoimmune serologies were all performed, which were negative. So these are the images from this particular case. And if you look at the left picture, which is a trichrome stain here, we do see some nodular glomerular change, which is low power. I will show you the higher mags. But what I wanted to show you in these images is the clusters of lymphoid cells, some nesting and some aggregates that are infiltrating the inflammatory, the tubular interstitium, along with occasional red blood cell casts. And these aggregates appear to be relatively monomorphic. They are infiltrating the tubules and also disrupting some of the tubules and occupying the interstitial space. So with the suspicion that we had that could this be an infiltration of the CLL cells, like a small cell lymphoma, a tissue phase of a chronic lymphocytic leukemia, predominantly as we expected, it was B cell positive, CD20, and kappa was positive more, and lambda was totally negative. And the T cell category was not very much, except a few sprinkling of cells. CD23 is a marker for CLL, B cell lymphoma or leukemia, and CD5 was also positive in this setting as well, which sometimes can be seen with T cells too. So all of this made a diagnosis of an infiltrating leukemia cell or the tissue phase of CLL. But let's come to the glomerular findings. Clearly, the range of a membranoproliferative glomerular pattern of injury was seen with double contours, the nodular sclerosing pattern that we see here in the mesangium. And by immunofluorescence, it was mainly IgG kappa. Lambda was essentially negative, and there was some evidence for C3 or complement activation as well, which is not unusual at all. And by electron microscopy, we had a typical picture of an advanced membranoproliferative pattern of injury. So we see the glomerular basement membranes here. It's a high power view with subendothelial monoclonal deposits. And we have the new basement membrane formation, which gives the double contours and some cellular interposition. And we see that in this capillary loop as well. And we saw the deposits in the mesangium too. So this was the diagnosis that we had made at the time: diffuse membranoproliferative with nodular sclerosing changes with monoclonal IgG kappa and C3 deposits, which were mainly IgG1 subtype, which we were able to do. And so this would fall into the category of proliferative glomerulonephritis with monoclonal immunoglobulin deposition by way of the proliferative nature, the C3 deposition, and maybe the undetectable monoclonal gammopathy that we have. This resembles the usual MPGN pattern. In addition, we did see atypical lymphoid infiltrates, which were IgG kappa positive, and immunophenotyping confirmed the tissue phase of lymphoma with CLL. And the follow-up, the patient was treated with the daratumumab. 3 years later, the counts came down to 15 to 18,000. The creatinine stabilized at 1.9 with persistent nephrotic, subnephrotic proteinuria. So this, from the hematologic realm, it would fall, it is a B-cell lymphoma, would fall under the BCLL forms of B-cell lymphoma leukemias right here, very nicely. So not only do we see this type of picture with a monoclonal gammopathy that can occur with CLL, with or without monoclonal gammopathy, because it's a B-cell lymphoma, it can produce small levels or larger levels of monoclonal proteins. But we can also see podocytopathies. On the right side, we see minimal change disease, and this patient also came with nephrotic syndrome. But when the biopsy was performed, what we saw was diffuse effacement of foot processes. We also have seen focal segmental sclerosis in a couple of patients as well in the setting of CLL. And very rarely we had this lady who had CLL with nephrotic syndrome, believe it or not, and a slight rise in creatinine. What again we found were infiltration of these lymphoid cells from the CLL within the glomeruli, and there were no deposits. So that can happen as well. So let's quickly go to case 2, which was a 65-year-old man who had a history, a known history of Waldenström's macroglobulinemia and lymphoplasmacytic lymphoma diagnosed within the within the lymph nodes and bone marrow 2 years prior to this. And he was currently actually on rituximab. A few months ago, he developed microhematuria and later proteinuria that progressed to nephrotic range. Creatinine also was increased or was going up at the time. And this time, they were able to identify a monoclonal gammopathy, which was IgM kappa, with a little lower C3, and sometimes that can happen too. There can be some complement consumption as a result. Plus, there was a cryopositivity as well. And often, you know, when they find IgM kappa, they do test for cryoglobulin, because nearly 30 to 40% of these patients can have the cryo activity as well. So again, when we saw the biopsy, this is what we saw, a typical picture, again, infiltrating the tubular interstitium. And this is a biopsy, a kidney biopsy, showing a couple of morphologies within the infiltrating cells. Atypical lymphocytes is one, but we also started seeing some plasmacytoid cells and plasma cells as well. So this was the typical lymphoplasmacytic lymphoma this patient was diagnosed with, and now is also involving the kidney. And the same thing with the immunophenotypic studies, we were able to identify the B-cell nature of the lymphoma with very little T cells. And we also localized the plasma cells in here, which were monoclonal, all of them were monoclonal kappa. And with the full immunophenotypic studies that were performed with the guidance of our hematopathologist, we were able to confirm this diagnosis. And immunofluorescence that we routinely do with kidney biopsies also localized IgM kappa as the type of the lymphoplasmacytic lymphoma where lambda was negative. And this was the glomerulus of this case, but I also added a couple more pictures from a different case of Waldenström macroglobulinemia. You can see a variety of patterns, mesangial glomerulonephritis, membranoproliferative, or a diffuse proliferative. And when they do have increased amount of cryoglobulins or increased titer of monoclonal gammopathy, you may see these cryoprecipitates within the capillaries or cryoplugs, if you will, and you can see them here as well. So the spectrum of glomerular lesions can vary Eventually, you may see a membranoproliferative pattern in the more indolent cases. And immunofluorescence also shows monoclonal IgM deposits within the glomeruli as well as in the cryoplugs. And by electron microscopy in this particular case, we did find the tubular type of deposits within the subendothelial area and subepithelial area, as well as in the mesangium. So it was everywhere in this particular case. So this is what we diagnosed in this particular case with monoclonal IgM kappa organized deposits that was consistent with this disease, along with the infiltrating lymphoplasmacytic lymphoma within the renal cortical and as well as the extrarenal tissue. You know, sometimes for us pathologists, when we start to look at everything and some extrarenal tissues included in our kidney biopsy, sometimes looking at them may also help us because some of these infiltrating lymphomas can have those lymphoid aggregates even in the extrarenal areas too. So this will fall into another differentiated B-cell lymphoma, which is the plasmacytoid lymphoma. Oh, this is going crazy here. So, and again, I think this is the most common form that we might see because it manifests kidney disease because of the monoclonal proteins. And again, a host of publications have arrived. This is just the recent ones in the last few years that I have quoted in terms of renal involvement and Waldenstrom's macroglobulinemia and the spectrum. One other entity, glomerular entity that I failed to mention is amyloidosis that can also occur in this setting. So I want to pause here before the next three cases, which is to talk to you about the spectrum of glomerular lesions in the setting of lymphoma leukemias. A host of minimal change. If you just close your eyes to the rest of the typing here, minimal change, focal segmental sclerosis, membranous, membranoproliferative, we see almost all the primary patterns of glomerular injury that are associated with a number of different types of lymphoma leukemias. So it is not unusual to see these, but what is unique is that these patients or these cases, if there is a monoclonal protein, they would localize monoclonal deposits within them. You know, MIDD can be also seen, monoclonal immunoglobulin deposition disease, with the typical pathologic features. Amyloidosis is fairly common with Hodgkin's lymphoma. And as I mentioned to you, the cryoglobulinemic GN. This can also occur in the low-grade B-cell lymphomas that we might see in the setting of hepatitis C. So in addition to the variability of the glomerular lesions, but why does this occur? Why is this variability? It depends on the type of lymphoma that we are dealing with, the propensity for this lymphoma to elaborate, the kind of monoclonal protein or a soluble factor, the level of differentiation, all of that matters in terms of how it manifests in the kidney or what kind of effect it produces in the kidney. More importantly, when there is a monoclonal gammopathy, it is the physicochemical characteristics of these abnormal proteins, the concentration of that protein, the rate of degradation, all of that, the affinity and the extent of glycosylation there. As I mentioned, the whole physicochemical characteristics are the ones that play a major role in producing the variety of patterns. And here are examples, some pictures, excuse me, to show you the minimal change, the focal segmental sclerosis, membranous patterns, the diffuse pattern, and focal proliferative lesions, and nodular sclerosing pattern. And just as well, we do see often monoclonal proteins in some of these cases. And that is the reason why we do kappa and lambda light chain staining on all of our kidney biopsies. So these are just to share with you the kind of organized deposits we see sometimes with these monoclonal proteins. And these are all from the lymphoma leukemias from our cases. And you can see the variety of the organization that they provide. Again, as I mentioned, this is based on the physical-chemical characteristics of these monoclonal gammopathies that they produce these pretty designs ultrastructurally within the deposits. And membranous glomerulonephritis, a membranous nephropathy with monoclonal proteins, is often a secondary form of membranous. So it may not often measure up to or compare to the idiopathic forms that we see, or the PLA2R forms that we normally see, because the appearance of the deposits can vary from one glomerulus to another. They can be confluent, they can be small, some of them can be resolving. So it's a varied picture that we see with a secondary form of membranous, and that's what we are seeing here, along with spike formation also in some of these cases. And in these patients, we may see mesangial deposits as well, which will also confer a secondary membranous. So one other thing before we move away from the glomerular lesions is the intravascular infiltration that can produce nephrotic syndrome. Here was a patient from our file, 70-year-old woman with a recent vision loss, hearing loss for 9 months ago, and recovered with steroids, but now presented with vague neurosensory symptoms. And there was a focal lesion in the brain, presented with nephrotic range proteinuria, but normal renal function. And this is what we saw with the biopsy. Most of the glomeruli showed varying degrees of occlusion of the capillaries by these atypical lymphoid cells, large atypical lymphoid cells, as well as the peritubular capillaries, which were engorged with these inflammatory cells. And if you see them in the transplant, this is something what we would call as, a transplant glomerulitis or an antibody-mediated rejection. I mean, it resembles that, not that it is. So that is the picture that we have here in this native kidney disease. And immunohistochemically, we were able to identify the monoclonality and the location of these abnormal cells, which are primarily in the microvasculature. So, and there have been a lot of publications, usually anecdotal publications of these such cases. And here was a review of literature of such cases, which was 16 patients from 2014, although I have seen case reports subsequent to that as well. And there was no age predilection of any kind, or the age range. Often they presented with nephrotic or a nephritic syndrome. 5 of them also had AKI in this particular case, frequently with fever and weight loss. Multisystemic involvement was seen in a few cases, including CNS involvement, as in our case. These patients were treated with the rituximab CHOP treatment. 10 had complete remission or remission. There were 3 deaths and 3 were unknown. So case 3, we will shift a little bit differently in terms of what we saw. This was 2 years ago, we had encountered this case. 63-year-old African-American gentleman who was originally from Dominican Republic, feeling poorly for 2 weeks, had AKI with creatinine of 1.8, hypercalcemia, and of 12, and lytic bone lesions. Myeloma workup negative, Everything else was negative at this time. Since it was the COVID time, we also did the PCR test, which was negative. So, and this is what we saw. There were large patches of infiltrating monomorphic inflammatory cells, or rather in lymphoid cells, mononuclear cells, if you will, separating the tubules, some also infiltrating the tubules. The glomeruli were fairly normal, and some parts of the renal biopsy was uninvolved. And if you get a closer look, you see how large and atypical these infiltrating lymphoid mononuclear cells are. It is fairly monomorphic in the sense no other inflammatory cells were admixed here, and glomerulus was fairly normal. And this was the picture that we saw. So we knew that this was some form of a lymphoproliferative disorder. So again, we start with the immunophenotyping of the infiltrating cells. This turned out to be, this is B cell. Now, B cells were totally negative. It was predominantly T cell. And CD5, which goes along with the T cells, was also positive in this case. So we now know that this patient had a T cell lymphoma infiltrating the kidney. Then we had to confirm the monoclonality of the T cells, and this being a controlled polyclonal T cell marker. By PCR analysis, the monoclonality was confirmed. This is a complete case. And further immunohistochemical analysis also showed a picture of a predominant CD8 subset of T cells, and that CD7 was mostly negative, very few cells that were positive there, which will again put it into the category of a malignant T cell neoplasm. And this was to confirm from the flow cytometry that there was loss of the CD7 when compared to the other pan T cell markers, which is a diagnostic marker. But we also went a little ahead because this patient comes from the Caribbean. So what is the cause of this T cell leukemia-Lymphoma? And we looked for the human T cell lymphotropic virus in this particular case. And this is a positive control, and you can see the patient was also positive for this. So this is what was driving this HTLV status. One status was the one that was driving the T cell lymphoma in this particular case. This is, as I mentioned, this was a complete case. A bone marrow was performed, and you can see the abnormal nuclei, lobated nuclei of the T cells, malignant T cells within the peripheral blood. Also, the count was not very high, but it was there. Bone marrow showed the same thing with immunohistochemical analysis. So this was a complete case of a diffuse infiltrating HTLV positive adult T cell lymphoma leukemia infiltrating the kidney, confirmed by everything, immunophenotyping, molecular studies. So anything that we can do to go ahead, and I have been very fortunate that we have an outstanding hematopathology department and a hematopathologist who holds my hand to work up these cases. So this, from the T cell neoplasm side, this is where this belongs, more of a peripheral T cell kind of a reaction. But I also want to let you know this is not the only way that T cell leukemia-Lymphoma can affect the kidney. There are also indirect lesions, often podocytopathies, minimal change, focal segmental sclerosis, as well as collapsing glomerulopathy. There have been a few other case reports as well, and this is from our own case, from in-house. So case 4 is, and we are now moving away from native kidney disease to transplant. I have, as in the audience, Dr. Kim Soles himself, who is synonymous with the band transplant pathology. And I just wanted to share this case with you of a 65-year-old male with end stage of polycystic kidney disease. So no evidence for, no room for any recurrent disease that we can consider at this time. He got his transplant from his wife, and the usual thymoglobulin induction steroid-free protocol was maintained. But eventually, this was 21 months ago, but 5 months ago, he developed EBV viremia. Before that, he was negative. And they lowered the immunosuppression. There was no BKV. Bone marrow biopsy at the time was negative, no lymph nodes. Later, recently, progressive lymphadenopathy, there was also, which showed nodular paracortical follicular hyperplasia, which was EBER positive. They localized that within the lymphadenopathy. And there was bone non-destructive plasma cell hyperplasia as well in that setting of the bone marrow. So, of course, the current presenting creatinine was 1.3 with no proteinuria. The reason why the biopsy was done was that because this patient was EBV positive and that now the patient had PTLD, they wanted to make sure what was going on in the kidney and how can we restart, what can we do with regard to the immunosuppression? Can we restart it? Is there rejection process in the kidney that is brewing right now? So that was the reason for doing the biopsy. And this was the whole biopsy. I just wanted to put this out to you, how patchy this can be. You can see some aggregates, some nodular kind of aggregates within the kidney tissue, while the rest of the kidney tissue was fairly normal. There was no rejection process, but this is what we need to now identify. What does it represent? Is it a PTLD? Is it just some chronic inflammatory reaction from the past, because now the graft is close to 2 years old? So if you get a little closer, there was active tubulitis. There was some tubular disruption as well. And with regard to the composition of the cells, which is so important, we found plasma cells in there. We found lymphocytes, relatively monomorphic, very few macrophages or other cells that were present. Some of these larger cells are actually tubular cells that show disruption as this is evolving. And when we did the immunophenotypic studies, there was T cells, there were B cells in these aggregates, and the plasma cells were both kappa and lambda positive. So it was a polymorphic infiltrate with a polyclonal deposit. So we were still in a quandary, okay, what does this represent, right? So if you look at the lymphoid aggregates too, they're both positive for kappa and lambda and kappa, and the plasma cells as well. So then we went ahead and did the EBER, in situ hybridization for EBV, and it was positive within these lymphoid aggregates. So then we do have now a diagnosis of a partial renal cortical infiltration by lymphoplasmacytic aggregates, which was EBV positive, consistent with post-transplant lymphoproliferative disorder, which is of the polyclonal or the polymorphous type. And this was confirmed by molecular PCR studies and IgA heavy chain, IgG heavy chain. There was no monoclonal component in the rearrangement, and the kappa and lambda were also, as you saw, were positive in this case. And this patient, on follow-up, they lowered in immunosuppression but gave rituximab in this case. 1 month later, the viral load came down, and 2 months later, it was undetectable, and the creatinine now, I'm thankful to say, it is 0.9. So what about the latest on the PTLD in general and also affecting the kidney? This is where our patient fell. These are the various forms of PTLD. Our former chair and also currently our hematopathologist are very instrumental in this classification. The latest classification is the 2017. So this is one of those that is reversible. Then when you get into the monomorphic or the more malignant forms, these and they can be from 12 to 30%. They have to be treated with regular immunosuppression. So, but what about the kidney involvement? These are generally self-limited in a way. Kidney involvement, it has a close relationship with Epstein-Barr virus. But this one large meta-analysis from various charts suggested some of the risk factors that may be involved. Those patients who are EBV and CMV negative at the time of transplant have a greater risk of developing PTLD when they acquire the infections. Also, others are older age group, the Caucasian race, and T-cell depleting therapies. Mortality and the death censored renal failure is also increased when there is a PTLD. Thankfully, it is less than 1% of the PTLDs, of the cases within the PTLD that involves the kidney. So now I want to pause before the case 5 and finish up the talk, which is what happens when we don't know these patients are coming with their history. So, and how do we look at them, and how do we suspect that there could be some underlying and go after them? Often in the older age groups, maybe a history of MGUS, now it is normal, and maybe a 10-year history or a 15-year history of lymphoma that is, the patient is in remission now, but we don't know. Biopsy findings, the abnormal pattern of infiltration, the cellular appearance, this is for the infiltrates as a matter of fact, and the composition of these interstitial inflammatory infiltrates. So that, again, with a high degree of suspicion, we don't have to do $1 million workup. We can start initially, if you do have a suspicion, with a T-cell marker, a B-cell marker, kappa lambda, and see where we are going, and then go further. And as I mentioned, similar infiltrates sometimes can be seen in the renal capsule, which is also raises your suspicion of whether this could represent that. The presence of concomitant glomerular lesions is very helpful when they have monoclonal gammopathies or other podocytopathies. So something that I want you to remember, because I fell into this trap, and I'm going to tell you, this was a recent case from last year. A 79-year-old, the biopsy was from a major cancer institute, and the patient had metastatic esophageal malignancy, was treated with PD-1 inhibitor for 4 months, and was off of the PD-1 inhibitor for 2 months. 1 year ago, he was treated with chemotherapy for 6 months to treat the malignancy following surgery, of course. Now developed non-proteinuric acute kidney injury, creatinine from 0.9 to 1.8 to a higher level. Patient was treated with prednisone. They were thinking it could still be PD-1 inhibitor, and tapered after 6 weeks, but the creatinine kept rising to 2.5. The kidney biopsy was done. This was the kidney biopsy, and this is what we saw. Again, anyone in the audience, I wish I was there in person, but when we see this kind of nesting, this kind of monomorphic or close, the adhesive appearance of the aggregates, for me, I felt, am I seeing a lymphoproliferative disorder in this older gentleman? Could this be something different from the original metastatic disease? And there is also tubulitis that you can see here. And this was also patchy, as you can see. Glomeruli were totally normal. And this was another area to show you a similar picture of, appearing monomorphic, meaning they appear so similar, so together that you would suspect a more of a neoplastic infiltrate rather than a reactive infiltrate. Although when we looked carefully, there were a few other cells that were admixed with this as well. And when we did the immunophenotypic studies, T and B cells, they were all very similar. And you can see the same thing here. There was no, there were majority of them were, that was B cells for that matter. But T cells, majority of these aggregates were T cells. This is a T cell marker. These were T cells. Again, we were confused. Could it be a T cell neoplasm? So that was the question that I asked our hematopathologist. So we went ahead and did additional T cell subset marker studies. And at that time, it was felt that the CD7 marker may be negative in a subpopulation of cells, which would raise a T cell clone. Okay, so we went further. We did a polymerase chain reaction for T cell receptor gamma chain, which turned out to be polyclonal. Thankfully for this patient, so there was no molecular evidence of a T cell neoplasm in this particular case. So these situations do occur, and this patient did have an interstitial dominant lymphoid aggregates with occasional plasma cells. Everything else was negative. The differential diagnosis will be, of course, a neoplasm, but maybe a systemic viral infection. And if there are more plasma cells, maybe an IgG4 disease or a Sjogren's. And sometimes this may represent a variant of checkpoint inhibitor associated tubular interstitial nephritis with the exuberance of the T cell, which is what we decided that this patient had. And eventually they continued to treat him with steroids, and they discontinued, since the PD-1 was discontinued, the creatinine improved somewhat, but I think 6 months later, the patient succumbed to his metastatic disease. So the last few slides, I didn't want to leave this talk without mentioning the primary extranodal lymphoma that can occur in the kidney. It's extremely rare, can be bilateral. By imaging studies, you can see it can be focal or diffuse involvement. And often these patients present with 60% acute renal failure. It can be in the interstitium, focal tubular infiltration, glomerular infiltration. There can be angiotropism. And the diagnosis is, of course, made by the morphology and the typing of neoplastic cells. Prognosis is often poor, depending on the extent of involvement, with some long-term survival. So what are the criteria to make it a primary renal, meaning the first presentation is in the kidney of a lymphoma? The initial presentation is renal failure or renal dysfunction, enlargement with destruction, absence of other causes of renal failure, diagnosis made by kidney biopsy or nephrectomy, and recovery of renal function after specific therapy after the biopsy. So this is one such case that we had in a child who was HIV positive years ago, developed Burkitt's lymphoma and renal failure. The glomeruli were totally normal, and the interstitium was infiltrated by the Burkitt's lymphoma. And that was also confirmed by the FISH study from the tissue, from the kidney tissue. This was a kidney biopsy. And another kidney biopsy showed follicular lymphoma, partly infiltrating the kidney. Glomeruli normal. Again, FISH identified the definitive translocation for the diagnosis. So having said that, now the conclusions. If anyone has joined very late, this is all you need to know. Virtually all major forms of lymphoma and leukemias may affect the kidneys, producing diverse glomerular lesions, tubular interstitial infiltration with renal dysfunction. That can be diagnosed by a comprehensive workup of renal biopsy tissue as much as possible. The immunophenotype of the lymphoma leukemia may influence the nature of glomerular lesions and the infiltrative pattern. Routine hematologic laboratory workup, including lymph node and bone marrow biopsy, are helpful adjuncts to confirm what we saw in the kidneys, to identify and confirm the diagnosis. As I mentioned just now, isolated or primary lymphomas are possible. A high index of suspicion is necessary to establish a diagnosis of PTLD because of the polymorphous nature of the infiltrate. And appropriate serologic and immunohistochemistry need to be performed. But above all, what we need is both nephrologists and renal pathologists, a close collaboration and consultation with our hematopathologic and clinical hematologists to confirm the definitive diagnosis, to plan further workup, such as molecular and other cytogenetic studies, and therapy, of course. So with that, I do give a special acknowledgement to my dear hematopathology colleague, Dr. Amy Chadburn, for her guidance and expertise at Weill Cornell Medicine. Thank you very much.
Thank you. Thank you very much. Surya, could you stop sharing your screen so we can
I will.
see you better?
Yes.
Okay. So Surya,
we
have several questions in the chat.
Okay.
So probably we can say so. But before that, let me tell you, this is a spectacular review. I enjoy it very, very much. And as you mentioned, these two things are needed. Well, the high index of suspicion, even if you don't have in your lab the possibilities to get any collaboration for hematopathologists, or you don't have the immunohistochemistry, identifying the origin of the disease, or at least having the idea that this must be or could be, is very important. So the pathology, the renal pathology, is the guidance is where the things start, and what we will, you will be able to send to somebody that can have the background, that can have all the technology for identifying. So I think it's very, very important to get at least the suspicious that this could be, right? Yes. And the other thing is, of course, you need a very sophisticated group of, collaboration with hematopathologists, and also a very sophisticated and a complete immunohistochemistry lab, and molecular, of course. So let's start with the questions. And okay, so the questions started since the very first case, so we will have to take it like this. Sure. So somebody is asking about, I think this lymphatic system in the kidney were already discussed, but somebody's asking about, usually CLL is not treated with daratumumab. Was the bone marrow negative? I think it was from the first case that has CLL and minimal change disease, I think. Yeah.
Right. Yes. That's a great question, because I think the patient was treated with the routine agents before, but now presented with the kidney involvement, with all of this going on. So, and the count being still very high, as you saw, it was about 80,000 at the time. So they wanted to, reach out to newer agents. And that was the reason why they started daratumumab in this particular case.
And our second question from Dr. Adehamid is asking, why lymphoma spreads diffusely in kidney?
That's a great question. There are several ways, right? These lymphoma cells can be also in the circulating blood as well, even though they may not be enough when they're only lymphomas. Then the leukemias, of course, are already in the bloodstream. They can, and also they spread along the lymphatics, but I think it is mostly via the peritubular capillaries and the bloodstream that they can get into the infiltrate the kidney. Yeah. Okay. And once some of them get there, they have this high index of proliferation. In one of the cases, I didn't show you the key 67, which is a proliferative index. And that was so strongly positive, meaning that they all do not need to come from circulation from outside. Once there is a seed within the tissue, and they get a foothold, they start multiplying and they occupy the rest of the kidney. That's why most of these are more indolent to begin with.
Yeah. So yeah, that's very important. You see, they start being indolent. So you can give a diagnosis when it's even preclinical, right?
Yes.
So that's not suspicious. So there's another question from Dr. Kinar Jaberi. We see a lot of AL amyloidosis with Waldenstrom and CLL. Any thoughts, though, to treat are not sure? If to give a Waldenstrom-based chemo or plasma cell-based chemo?
Well,
it's about how to treat amyloidosis or with Waldenstrom, with chemo or with or plasma cell-based chemo.
Right. With my limited experience in terms of treating, I'm as a hematologist, I'm not a hematologist, but the question, Kenar, is very well put. Nowadays, I think in Memorial Sloan Kettering and others, that just to get around this, they do bone marrow transplants and give them the preconditioning therapy and everything. And one of the ways to get around this is bone marrow transplants or stem cell transplants to get rid of that. Hopefully, it will get rid of the underlying malignant disease. But now, having said that, depending on what the bone marrow results are, whether there are plasma cells in there or whether there are lymphoid cells in there, now we have directed therapies to these cells that they tend to use.
Okay, and then, well, there's somebody asking, Dr. Jaberi again, have you noticed, or did you use NEL marker or NEL1 or FAT1 in lymphoma-associated membranous nephropathy?
That's a great question. We do not have it in our institution, and NEL became available for routine use at Mayo Clinic. We send our cases to Mayo Clinic only recently. So none of these cases were sent because these were older cases. So no, Kenar, we didn't do them.
Yeah, so Dr. Nayana Patil also was asking about the NEL, but I think it can be done now. So you can go back and
probably yes.
Yeah. Dr. Abud Razak, how could it be differentiated that the renal involvement is due to lymphoma itself or due to lymphoma in conjunction with ICP?
Well, I don't know. I think we have better experts than me with ICP in the audience, actually. I don't know how often we have seen a lymphoproliferative disorder in association with ICP. So it would be hard for me. And like I said, like what are the case that I showed you, the suspicion was based on the pathology and the pattern and the cells and how they were arranged, which didn't turn out to be a lymphoproliferative disorder. And immunophenotypic analysis can help us.
Yeah. So, and another question now from Dr. Abud Razak, what is angiotropism?
Angiotropism is where these abnormal or atypical malignant lymphoid cells have an affinity towards the endothelial cells, towards intravascular localization within the microvasculature, and that is angiotropism.
And what is your experience? This is from Dr. Hae-Jung Chung. What is your experience with cases of renal dysfunction suspected to be related to clonal hematopoiesis of indeterminate potential, CHIP?
Could you repeat that question again?
Yes, your experience with cases of renal dysfunction suspected to be related to clonal hematopoiesis of indeterminate potential.
Right. I think years ago, we have not had many of those cases. I'm sorry. But we had one case. Again, I had reached out to our hematopathologist to help us out with that. And I think it was of histiocytic origin, if I'm right. And again, the patient was referred to a hematologist, and I do not have a follow-up on that.
And we have a great comment from Tiffany Casa. Thank you for attending. She's saying
Thank you, Tiffany.
that of 115 patients with NEL1, membranous nephropathy,
Yes.
they have only one patient with lymphoma. So all the rest were solid tumors. Right? So it's not probably very common, but then only one case. Yeah.
Thank you for sharing, Tiffany. You know, it could be, I don't know what your explanation for that is. It could be that the lymphoma is producing that, or is unearthing, exposing that, or there could be coincidental. It's hard to say. Thank you.
Yeah. So I think it was our last question. And thank you very, very much. I appreciate everyone for your comments. And of course, Surya, another great contribution for teaching. I loved your presentation. And I think it was very interesting, many comments, many questions. And I think it's a great topic that we need to keep looking at, investigating. So you want to say something else, Surya?
Well, I just want to thank the audience, and now I see within the audience, I see many outstanding nephrologists and renal pathologists who have joined. I'm very honored by that. I'm honored by this opportunity to share our experience, and we'll keep learning. Thank you very much, Carmen.